Okay, so hello everybody. Really sorry I can't be with you here in person today. I've recorded a presentation around the VIP's framework and a few reflections on hospital care and people living with dementia, which I hope you'll find useful. So in this short lecture today, I want to start off by just expressing humility and thanks, really. For people living with dementia and their families, and for staff, hospitals are really difficult places to enact person-centred care. They're difficult to be in as a patient, they're difficult to visit, and if you are working with a number of patients living with dementia on a busy ward, they're also very difficult places from a staff point of view and a professional point of view. And I just want to thank each and every one of you for really, taking the time today and making the effort to try and make this right, because if we can get hospital care right for people living with dementia, that would be such a great benefit to all of us. I often use this illustration of poor old Sisyphus pushing a big boulder up a hill, and he's been damned by the gods that as soon as he pushes it up a few inches, the heavy weight of the boulder rolls down back on him. And often I think providing good hospital care for people living with dementia can feel like that. We make a few breakthroughs, we get our systems up and running, we make our hospital more dementia friendly, and then we hit the next crisis and the boulder rolls back down on us again. And I think, that this crisis that we've all been living through for the last few years of COVID has really taken so much strength and energy out of us all. And I think it's very opportune now to really start thinking again about helping people with dementia who are our patients in hospitals and how to make it better for them. So this afternoon, or whenever this is being broadcast, I'm going to do my bit by putting my shoulder to the boulder and trying to articulate a bit about our evidence-based person-centred care and giving you an overview of the VIP's framework. Now, we actually have a very strong and enduring theory of person-centred dementia care here in the UK. The late Professor Tom Kitwood first started writing about the importance of person-centred approaches to dementia care way back in the last century, drawing on the work of Martin Buber and Carl Rogers, and really then recognising that people living with dementia were people first, that dementia happened in the context of their lives. And a lot of what we have the opportunity to do in dementia care is to try and support the personhood of those living with dementia. And he developed some key enduring theoretical standpoints, like the enriched model of dementia. He talks about the importance of psychological needs in dementia, and this eradication of malignant social psychology and the promotion of positive person work. Now, these are heady theoretical things that Kitwood was writing about. And one of the joys that I had a couple of years ago was Kitwood's first book on dementia, on person-centred care, called Dementia Reconsidered. It was actually written in 1997, and it is such a well-thumbed textbook that any of you who have been students in dementia studies or who have ever delved into person-centred care would have come across. But it is an old book now, and essentially these are the 9 chapters that you'll see on the slide here that Kitwood wrote way back in 1997, drawing a lot on the work that he was doing in the late 1990s. And as the 20th anniversary of that publication came upon us, Open University Press asked me whether I would do an edited version of the book, whereby we took each of those 9 chapters, and for each one had a contemporary expert in the field to write what had happened since 1997. And that became Dementia Reconsidered, Revisited, which there's a copy of on your screen. And essentially, virtually for chapter, what the contemporary experts were saying was that the theoretical models that Kitwood developed way back in the 1990s still stood today, but actually what we have now is a lot more evidence and know-how for how we enact these aspects of protecting personhood in practice. This doesn't mean they're easy to put into practice, but we do know already a lot of the things that really help people to live well with dementia or to have a good patient experience. What's really changed over that time period, though, is the numbers of people living with dementia and also the time that people are diagnosed with dementia. I've been working in the dementia care field for a long time, nearly 40 years now. And certainly when I first started working in the field, dementia was a relatively rare condition. You know, if we had somebody on an acute hospital ward with dementia, we'd immediately call a psychiatrist. If we had somebody in a care home with dementia, it was a big deal. Whereas now, because of our aging population and because we have so many more thousands of people living with dementia, particularly into old age, you know, so people in their 70s, 80s, 90s living with dementia, who, if you're in your 70s, 80s and 90s and you have a dementia, you know, the chances are you've got 4, 5, 6 other long-term health conditions going on as well. So of course you're going to end up in hospital. It's inevitable at some point. And also our care homes are now, 70% of care home beds will be for people living with dementia. Now, those on an individual basis, for those people living with dementia, their lives are no less complicated than they were 30, 40 years ago. But now we are, as a health service and as a social care service, working with many more people. So now dementia is everybody's business. It's not specialist care. We still need our specialists to advise us, but by and large, all of us and all service settings need to be able to support those living with dementia. And the other thing that's changed is that we are diagnosing people at a much earlier stage. Again, you know, even I'd say 10 years ago, we were mainly diagnosing people at later stages when their capacity and insight to understand what was happening to them was becoming much more impaired. Now, with our memory assessment services, most people are driving themselves to their dementia assessment. You know, we are now have a whole cohort coming through, COVID permitting, who actually are being diagnosed with dementia at a time when they can talk about that dementia, understand what it means for them and their family. Nobody wants a diagnosis of dementia, but if you have one, at least that empowers you to take some control over your future. What's endured in that Kitwood work, though, I think, is that the recognition that people living with dementia, their psychological needs are paramount. And often, if they are in receipt of care in hospitals or in care homes, those needs can easily be overlooked unless we make a real effort for them not to be. And that's when the boulder starts rolling down on us, you know, when their people's needs get squashed and marginalised. So that is as true now as it was when Kitwood was writing it in the 1990s. And I'd share this quote here of this was our experts, Keith Oliver and Reinhard Guss, who did the commentary on the Dementia Reconsidered Chapter 5, which was looking at the experience of dementia. Keith himself was diagnosed with dementia a number of years ago, and he wrote this about that kitwood flower, about those psychological needs. And he said, an early collaborator and professional friend, Michael Miller, showed me the kitwood flower and explained it in context, and then more importantly, consistently demonstrated through his actions and support what Kitwood would have wished all professionals working with people with dementia to demonstrate. And Keith said, I carry the Kitwood flower with me every day, glued into my diary, and if ever I had a tattoo, that's what I would go for. So those psychological needs, that need for attachment, inclusion, warmth, love, occupation, all of those things are important, whether you're a person early on in your diagnosis or whether you are later on in your diagnosis. And that's changed, that has endured. But what still challenges us is for that person living with dementia to experience care as though it's seamless. You know, people now live with dementia 10, 20 years. If you're thinking, you know, if we're diagnosing that early, people have got a long trajectory ahead. And still we treat care as episodes of care. We don't join that up around the person. And for each of these bits of this jigsaw puzzle, if we can't achieve that partnership working that is essential for the person living and dying with dementia, then at some point we are going to be failing people. So just moving on now to Care Fit for VIPs. We all need to know what good looks like. You know, what does good person-centered care feel like, sound like, look like? And who has to do what to make that happen in reality? And this leads me on to the Care Fit for VIPs definition. In trying to define the definition, I looked at lots of research from around the world. And it's a nuanced definition. I think there are 4 parts to it. It's more than just individualised care, person-centred care. If we're really going to be promoting the personhood of somebody living with dementia, our care has to value people regardless of their cognitive ability or age. We have to make an active effort to value people. Of course, it has to respond to people as individuals and recognise that everybody living with dementia has their own needs. It, though, also has to incorporate that ability to take the perspective of the person with dementia. So for us as professionals to be able to reflect on, what does this service, what does this intervention feel like for this person? And it has to provide that supportive social psychology. We have to have a social milieu that helps people to feel socially confident and included. So if we look at that from an individual perspective of being a person-centered practitioner, we have to be able to show that our actions respect, value and honour this person. We have to be able to reflect that, you know, on our actions, whether we are treating this person as a unique individual. We need to reflect, you know, am I making a serious attempt to see my actions from the perspective of the person that I'm trying to help, and how might my actions be interpreted by them? And do my actions help this person to feel socially confident and that they're not alone? And you can ask these 4 questions of yourself, you know, if you're giving an injection, if you're helping somebody to eat their meal, if you're helping them to, if you're doing a leg dressing, or if you're running an activity group. It's not that the action itself, or it's not the activity itself is about is person-centered or not. It's more about the way in which something, the way in which that intervention is done. So it's not what you do, but it's the way that you do it, I think would be what would get your results in terms of preserving personhood. And that definition got picked up in the NICE guidelines in 2006 and again in 2018. So at the beginning of the NICE guideline on dementia, it says that we should be acting in a person-centered way, and it defines person-centeredness in accordance with that VIP's definition. And NICE guidelines only have things in them that are evidence-based. And so I think if we unpick each of those, we have evidence to suggest that if you enact valuing, individualized perspective and social environment on a regular basis, then the outcomes of people living with dementia are so much better than if we don't attend to that. So I then took this work a bit further. So we had this 4-point definition, the V, the I, the P, and the S. And so looking at care provider organisations, what does that mean in practice? And more importantly, who needs to do what to make it happen on an everyday basis? So you see, we've got these 6 indicators here for valuing. And now I would suggest mainly within a hospital setting, those are going to be set by the senior leadership team within your hospital. The vision, human resource management, management ethos, training and staff development, service environments, quality assurance and governance. Those are the things that are set by people higher up in the organisation. Then if we're thinking about how we deliver individualised care, care pathways, care planning, regular reviews, personal possessions, individual preferences, life story work, activity and occupation. If you're going to get individualised care happening on a regular basis, those are the sorts of indicators that you'd expect to see being fulfilled within a hospital. And those are all things that need quite complicated processes building around them. So those tend to be enacted and led by your clinical leads, your senior nursing, medical, OT, physio, paramedic type people who are going to be putting those into place on a regular basis. Perspective, how do we ensure that the perspective of people with dementia is understood? And that will often come down to whoever's in charge of the ward on that day, your shift leader, who will be role modelling and monitoring skill communication, doing that balance between empathy, risk and decision making, ensuring that the physical environment is managed to the comfort of patients, ensuring that physical health needs are picked up quickly and enacted upon, responding to those difficult distress type behaviours or behavioural and psychological symptoms of dementia, and advocating for people when their needs are at odds with others on the ward. And then we have the social psychological milieu and environments. Are people included or talked over? Are they respected or disrespected? Are they met with warmth or coldness? Are their emotions and needs validated or sidelined? Are they enabled or done to? And are we making an effort to ensure that they're still part of their family and community? And that comes down to everybody can play a part in that. So on a holistic, we're looking across a whole hospital, we need all of these things to be working together to ensure that person-centred care becomes a reality on a sustained basis. And that's where we also developed the Care Fit for VIP's website that you will hear about today, and that Improvement Cymru have put more effort into updating this website that we've been using since 2012 to really help underpin the work within hospital care for those living with dementia. And as you go through that Care Fit for VIP's website, you'll be asked to reflect on, when we look down those 20 odd indicators, what are our strengths? What are we doing really well? What are our weak spots? And what's my sphere of influence? You know, I might not be able to make all the training happen across the whole hospital, but I might be able to do a project around life story work on my ward, you know. So it's also about thinking each of us play our part, regardless on the level that we're working at within the hospital. So in a bit more depth here, you know, these would be the 6 questions we'd ask about, does our hospital really value people living with dementia? And for each of those 6 indicators, we would reflect on, are we doing an excellent job here? Happens all the time. Are we doing pretty good? You know, happens some of the time, or we've made serious efforts in that area. Are we doing okay? Yeah, it's a bit hit and miss, but we've got some areas of good practice. Or does it need really serious work? This is something where we haven't got off the ground at all yet. I'm going to be sharing some photographs of people, some lovely group of people that I work with in Wolverhampton NHS Trust in the Midlands near my university at Worcester. And that's really your senior NHS trust, you know, your chief executive, your director of nursing, your lead consultant, your medical director. Those will often be steering what happens at that high level of valuing patients with dementia in hospitals. And, you know, thinking about what happened in England, certainly with the national audit of dementia, because there was a very big push to audit at quite a public level how well hospitals across England were doing on the different standards within the national audit. You know, that was something that trust boards took very seriously in England. And we saw some very big strides being made on defining the dementia care pathway. The percentage of hospitals that had a dementia care pathway was only 6% in 2011, and it increased to 2016, had increased to 61%. Having a dementia lead went from 0 to 97%. At least somebody got the title that it was in their job, even if they weren't perhaps actively doing it. Dementia training and hospital board reporting. So that high level, you know, the work you've got going on from Improvement Cymru will be really important in bringing this on the agenda of your higher level people working in your health boards. The next set of questions would be around supporting individuals living with dementia. Again, you've got these 6 indicators. Are we doing excellent, good, okay, needs more work? And on the website, you'll see each of these indicators unpacked, and it gives you the opportunity to really sort of make a good assessment of, well, how are we doing on these individual indicators? And as I said, these tend to be the senior clinical team. Again, we've got the modern matron, we've got the head OT, and we've got the lead consultant for care of the elderly. You know, that's the work that they often are involved in pushing forwards. And certainly, you know, this often starts with these sort of high impact, innovative pilot projects. So thinking about, okay, so what happens if we start using patient passports? What happens if we try really to reduce ward moves? What happens if we have a facilitated activity room within the ward for patients with dementia? So through these pilot projects, you can really start to move forwards on some of these more structural, individualized care indicators. Then your next piece of the jigsaw puzzle is understanding the perspective of people living with dementia. Again, for these 6 indicators: excellent, good, okay, needs more work. And this is your ward team, you know, people leading the ward team at different levels and within different, with different levels of responsibility. And certainly in this ward, which was a medical ward focusing on the needs of people living with dementia, they made a really serious effort to implement what they called a dementia care bundle, which meant that they knew key information about people within 24 hours through a This Is Me documentation. They did effective communication based on that This Is Me documentation. They really made sure that people were well fed and well hydrated, and they provided a safe and orientating environment. So applying that as a standard of care, that dementia care bundle, that meant they were putting in place things that would enable that person living with dementia to feel understood, to feel safe, and to feel included, was an important perspective type project operating at ward level. And if you put that sort of behaviour change into operation, if your This Is Me is completed on admission, it means you have good conversation topics, you know about signs of distress, you are recognising patients and families as partners in care, you improve your dignity and respect, you lower levels of distress. That will, of course, lead to improved outcomes, low levels of restraint, either physical or pharmacological, decreased untoward incidents, and decreased complaints. Simple. And then finally, providing that ongoing social and psychological report, those things, you know, the inclusion, the warmth, the respect. How are we doing on that on an everyday basis? Excellent, good, okay, needs more work. And that's the responsibility of everybody. And forgive me, I don't know the name of this gentleman. This was a ward I was visiting, actually down on the south coast, and I became very, very taken because it was actually it was a ward that was named after me, and on that bucket it actually says Brooker. So I had my photo taken with the guy with the bucket. But if the guy with the bucket, who is part of that patient environment, if he's not showing inclusion, respect, warmth, validation, and enabling and being welcoming to people's families, then the social psychological impact of that will be felt by the patient. So this has to go through all staff who have contact with people living with dementia. And things like John's campaign, you know, involving when somebody with dementia is hospitalised, the medical staff should do all within their power to make access easy for families and carers, and to utilise their expert knowledge and their love within that patient's stay. And to top it all, though, you know, is that sort of, we can get all that right in the hospital, but what happens when people are discharged from hospital, you know? Because if we don't discharge well, then either people will end up being readmitted to hospital quite quickly, or their health will deteriorate to such a level, you know, that and their quality of life could be very poor. And I just wanted to finish by sharing with you a set of photographs that are quite old now. But it was when I was working with a care provider called the Extra Care Charitable Trust. And they were doing a project on implementing person-centred care within their care home. And they were particularly interested in increasing their activities in the care home, and took a lot of photos over a period of a few months. And this was a photograph taken of Mrs. May Williams. And this was 6 days after she'd been admitted to this particular care home. And her care plan is in the yellow at the top of the page there. She had dementia. She had had a hospital admission. She'd been quite unwell. She'd had a chest infection, had been in hospital, I think, for 7 or 8 weeks, and had become very poorly, but had survived. And she came to the care home with this care plan, which said all needs, no mobility, not eating. So in a sense, you know, she was being discharged to essentially probably past and to end her days in an environment that was more conducive than an acute hospital ward. Now here she is 1 month later, and she's baking. She's making a bit of flapjack. She's been a homemaker all her life. She might not be able to make a complex Sunday dinner, but she certainly knows what to do with some sticky flapjack mixture. And here she is, obviously enjoying that. Good infection control, got her blue rubber gloves on, but obviously enjoying the moment of making and potentially eating those later. Here she is 6 weeks later. The home are doing an Italian night, and she's certainly looking a lot fuller in the face and looks like she might now be eating. Here we are, T and Teddy. Trying new things. She's having an Indian head massage here. I doubt whether May Williams had ever had an Indian head massage in her life before, but 2 months later was evidently enjoying that. Old skills returning. She, you know, again, might not be able to make a fair hour jumper, but she certainly knew what to do with wool and knitting. Silk scarves, activity. And 3 months later, here she is up dancing to music. And I think this was a Mexican celebration that they then had. And this is the same lady, you know, who was all needs, no mobility, not eating. And this, I think, illustrates for us, you know, what good person-centered care can do. The care home didn't think they were doing anything remarkable. They were amazed when they saw these photographs of May throughout that time period. You know, we could say there were lots of interventions that were going on there, that weren't particularly high level, but it was about that good quality, person-centered, everyday care. And the outcomes, obviously, I think for this lady, she probably wouldn't have been alive had she not gone to a care home in that took her personhood so seriously. So lots of people to acknowledge today, and particularly thanks to everybody at Improvement Cymru who's worked so hard on the launch today and getting this all sorted. And I just wish you all the luck in the world, and do keep in touch with us, and I hope to see some of you in the near future. Thank you so much for listening.